27, 29, they're growing up. So anytime ready to start engaging them, you can.
Good morning. We're going to wait just one more minute to allow additional participants to log on, and then we'll get started.
We got about 100 people on.
Good morning, everybody. Happy Tuesday. I'd like to start this session today with a quote that I came across this week. We may encounter many defeats, but we must not be defeated. When I saw that quote, I wondered what Maya Angelou was experiencing when she wrote it. I wondered if she was experiencing a worldwide pandemic, an opioid epidemic, the biggest hurricane to hit her state, one of the biggest hurricanes to hit her state in modern history, unprecedented deaths surrounding her, heightened job loss and food insecurities, online schooling, and painful widespread social injustice. You have to wonder if she was experiencing what we're going through now. Good morning. My name is Karen Stubbs, and I'm Assistant Secretary of the Louisiana Department of Health, Office of Behavioral Health. On behalf of the office and the department, welcome to the first ever Behavioral Health Symposium and pre-conference today on Louisiana's opioid response. It feels that we are saying first ever so many times these days that it's kind of lost its impressiveness. So on behalf of everyone at LDH, welcome. I'm glad you're participating in our pre-conference for the entire summit, which is entitled Changing the Conversations in 2020, Recovering, Rebuilding, and Rejoicing. And when I saw the title, as I was reviewing it yesterday, Changing the Conversation in 2020, I laughed to myself and said, boy, did 2020 change the conversation. The Office of Behavioral Health is pleased to co-sponsor this summit to bring awareness to conditions that our residents face on a daily basis and to highlight the evidence-based strategies being implemented. Today's pre-conference, as I said, will focus on Louisiana's response to the opioid epidemic. We're doing things a little bit differently today. We have 3 sets of panelists, but because of physical distancing, we're not all on the screen together. Our panelists are sitting off to the side in order to be spaced apart. So as we get to each of them, they'll walk up and join me on screen. And then Dr. Dunham is zooming in from New Orleans. She's our last panelist and will join us. So I assure you, we're all here in the room together and ready, although it looks like there's just one at a time. But as with everything in 2020, everything's different. The panelists I'm very excited about today, they'll all take a different spin on their response to the opioid epidemic. We'll start from a statewide perspective, look at a law enforcement and regional local perspective, and then look at addressing the opioid epidemic from the treatment perspective in a local way with Dr. Dunham. Louisiana released our opioid response plan in September of last year, so 1 year ago. which started the dialogue and identified ways the state was addressing the opioid epidemic. Within the plan, there are 5 pillars that we targeted to help drive data, identify prevention, intervention and treatment services, and help those in recovery. A little bit more about those 5 pillars, because you'll see each of them touched on in their own way throughout our 3 presenters. The first being data-driven. OBH, along with OPH, and really with OPH at the lead, received support from both SAMHSA and CDC to help address the opioid problem from a data perspective in our state. Since March, however, and the impact of COVID-19, we've seen an uptick in the number of Louisiana residents who've experienced overdose attempts and deaths. Partly contributed to the loneliness and isolation experienced during the epidemic. Nell is here to join us with some fascinating data that's going to highlight those numbers. And I believe she told me as we were discussing before the conference, this is hot off the press. So the first time we're going to see these numbers on a statewide level, and I encourage you to really stay tuned because it's staggering. OPH has also developed a platform for residents to use to go to for data on specific parishes. This website's amazing. Nell's going to highlight the website and how to access it with a couple of screenshots on what you can look forward to seeing there. So I'm really excited. I always love to hear Nell talk about data. The second pillar in the opioid response is around prevention. Of course, widespread education and awareness activities have continued to ensure that accurate information and resources are available in Louisiana. The Louisiana Center for Prevention Resources has also been established as a hub to provide information on substance use and misuse in our communities. It reaches out and trains professionals and provides information to the public. We also, within our Behavioral Health Summit, have a session to address non-opioid pain management techniques, which is also an area of opioid prevention. The third pillar in the response is around intervention. Enhancing our capabilities to provide intervention and rescue activities through increased accessibility of naloxone in our communities is essential. Over the past 2 years, the Office of Public Health and the Office of Behavioral Health and other statewide entities have really focused on getting naloxone into the hands of community members, both professionals and residents of Louisiana. The Louisiana Board of Regents has also unanimously passed a policy allowing institutions of higher education to have naloxone availability on college campuses. The Office of Public Health's Overdose Data to Action Grant, I always have to slow down when I say that, Nell's laughing at me on the sidelines here, works to expand the capacity of public health workers to coordinate with behavioral health workers for outreach and coordination of information to the public. The fourth area or pillar of our response plan is, of course, treatment. We have received numerous grants over the past several years that we've utilized as an opportunity to expand and provide services to those in need, specifically focusing on medication-assisted treatment, MAT, and a comprehensive approach to address opioid treatment. In January, Louisiana was pleased to announce that Medicaid started reimbursing for methadone treatment. This was huge, and quite frankly, it was about time. Since then, we've seen an increase in the number of Louisiana residents receiving methadone treatment through our OTPs, opioid treatment programs, that we contribute specifically to Medicaid coverage. In addition, Louisiana began our first methadone clinic operating 24/7. So around the clock. Traditionally, OTPs, or our methadone clinics, have had early morning hours, and we decided to experiment with a 24-hour clinic. We are one of what we think are only about 4 or 5 in the country experimenting with a 24/7 clinic. So we are very proud of that. The last pillar in Louisiana's opioid response plan is around recovery. It's very fitting that we're having this pre-conference in September, which is Recovery Month. We are joining Louisiana residents who are in recovery in recognizing their journey to address substance use disorders in their lives. Recovery support services are an integral part of the plan, so we can meet people where they are and ensure that they're getting the adequate support they need to stay in recovery. The Governor's proclamation for Recovery Month is included in your virtual summit brochure. Another important part of recovery is the utilization and reliance on peer support specialists, who are people with lived experience who have been trained to reach out to those in recovery, to lend an ear and a helping hand. We also support Oxford Homes and the Oxford Home model across the state that have provided opportunities for sober housing. That's a summary of the 5 pillars of the response plan. You'll hear our panelists touch on different components of that in their presentations. Louisiana, LDH, and its partners are working together to update and release a new opioid response plan that has been slightly delayed due to the events of 2020, the unanticipated events of 2020. Once that is finalized, we will solicit comments from the public to help shape strategies and those recommendations ongoing. We're also collecting best practices during COVID-19 to inform the plan, and will continue to provide training and technical assistance to professionals to outreach in Louisiana communities as they did prior to the coronavirus and in these unprecedented times. So at this point, I'm going to introduce our panelists. You know, in the darkness, you see stars. Is one of my favorite quotes from Martin Luther King Jr. And I have to say, it feels like we're cloaked in darkness sometimes in 2020, but the stars have really come out on this panel. We have some really impressive speakers. I'm pleased to facilitate this discussion, although it's kind of a strange facilitation as we take each other one at a time. Today, our panelists will give an overview on data around opioids, share some local data from East Baton Rouge Parish and perspectives from the district attorney and his office, and provide a local behavioral health perspective and strategies for reaching Louisiana residents in the metropolitan area. We have joining me on the panel, which you can't see right now because we are socially distanced, but you will see them as they come up to present. We have first Nell Wilson from the Office of Public Health, who's such an amazing presenter and has such a mastery of the data around opioids. We have District Attorney Hillar Moore and his section chief of his crimes strategy unit in the DA's office, Mr. Steve Danielson. And we have one of my mentors, Dr. Rochelle Dunham from Metropolitan Human Service District in New Orleans, who will be joining us through Zoom. And to wrap us all up, we have the Department of Health's Deputy Secretary, Mark Thomas, who will close us out with final remarks. So Nell, I will invite you up to the panel. You are first in line. I know you have a presentation. Nell Wilson again is with the Office of Public Health. She has a PowerPoint showing some data on Louisiana data. Where are we now? So at this point, Nell, I will turn it over to you. Might take us a second to get her set up.
Well, I can say that I am not going to be as polished speaking to a room full of technology equipment and myself as you were. So thanks for that. I just want to make sure that we have the PowerPoint up where our participants can see it. So my name is Nell Wilson. I am the project director for the opioid surveillance program in the Office of Public Health. The Bureau of Health Informatics, which is the bureau that we're in, we are the centralized data analysis and visualization hub in OPH. So it was a fit for the opioid surveillance program to be created in the Office of Public Health, and we are very grateful and very proud of the work that we have done. Most recently, you have probably seen the work of health informatics if you have checked the COVID dashboard at any point during the pandemic. That's another one of our products. Our opioid surveillance initiative has a guiding principle that we cannot manage what we cannot measure. And so we are here to measure the burden of the opioid crisis in Louisiana so that our agencies can make data-driven decisions that will reduce the impact of opioid use disorder in the state. To do this, we rely heavily on our partners to provide data that supports our efforts and also helps with implementation. We are funded by the Center for Disease Control and Prevention and also the U.S. Bureau of Justice Assistance. We have, along with our partners in the Department of Health, our closest ally being the Office of Behavioral Health, we also partner with the Board of Pharmacy, the Hospital Association, the Coroners Association, the DEA, the Department of Corrections, the Louisiana Emergency Response Network, state government officials, local and parish representatives, and then all of our stakeholders in the private sector. We are in our 5th year of our opioid surveillance program. Our main activities are listed here. We recently expanded to include all drugs in addition to the opioid work that we had done. We're mostly looking at stimulants and benzodiazepines. This is because often drug overdoses are the result of a combination of multiple drugs. So we found that in the first 3 years of this project, and we've evolved in our surveillance to include all drug types. I am going to be focused on the opioid outcomes today because this is an update of the work that we are doing to support the state's opioid response plan. We know, I'm going to highlight these boxes at the bottom. We know that opioid use disorder occurs on a continuum, and there are multiple points of entry into the various services. So when we started this, we started trying to assemble as many health outcomes and utilization data sources as possible to fully measure the impact of the opioid crisis on all points of service. The solid green boxes along the continuum are the data sources currently available in our online data tool. So we have the state's vital records, which includes deaths. We have inpatient discharge claims data. We have emergency department claims data. Through our partnership with the Board of Pharmacy, we're able to publish prescription drug data. And then we recently added a treatment locator into our online tool just to make it easier for people to one-stop shop resources. The lighter boxes are measures that we are currently acquiring or analyzing, and we will be publishing in the new grant period that we're in right now. So we have first responder data that's going to give us information on naloxone administration. We also are partnering with the Office of Behavioral Health to include treatment utilization in our data analysis, and then also social determinants of health. So we want to look at risk and protective factors and social determinants of health that feed into substance use and substance abuse disorder, like housing, educational attainment, poverty, those things that also I'm aware in these conversations that we have had with behavioral health are also on the back end important to sustaining recovery. So we have our cornerstone dissemination project in the opioid surveillance program is the Louisiana Opioid Data and Surveillance System. This is a public-facing, queryable data system that reports on fatal and non-fatal overdoses and the state's prescribing patterns. It is intended for health professionals, researchers, and decision makers to apply data to opioid abuse reduction efforts. So this is a static image. You can also find this on the LDH Opioids webpage. At the top, I don't know if my speaker box is hiding it, but there's a video tutorial link at the top. It's 4 or 5 minutes. It'll show you how to work, all of the features that we have in LODS. The colored boxes at the top will automatically populate the results for those measures. And then you can also at the bottom choose from dozens of different measures on 4 topics. We also have, you can subscribe to updates once you get into LODS and find it helpful. There's multiple places where we have treatment information available, and then you can reach out to us directly with any questions that you have about LODS, or any data that you need that you don't see in here. So this is a results page that you'll find. We have a map. The site has the functionality to be able to compare multiple parishes at the same time, also different ages, different demographics. You also get we don't have it checked because it doesn't fit, but there's a table where you can get the numeric count for every parish. We offer you to be able to download this in a CSV and also in a PDF. So that is our LODS tour. We'd love for you to go look at the site. Hopefully you find it useful. It's continuing to evolve. We have lots of ideas for how we can make it better, how we can make it more useful, but we would also love if you use it and think of things that would be helpful to you to reach out to us and let us know. So for the data presentation part, I think it's important that we start with some of the national statistics. The CDC data that's released, it typically takes them a couple of years for the data to be final because they're collecting from 50-something states and territories. So any data in 2019, they're calling a prediction. They are predicting a 6.6% increase in drug overdose deaths in 2019. Of those drug overdose deaths, 74% of them involved an opioid. Of the deaths that involved an opioid, 73% involved a synthetic opioid, which is typically fentanyl. And then this statistic, unfortunately, hasn't changed in the last 2 years, that 130 Americans die every day from an opioid overdose. The importance of a statewide surveillance program like ours is that while we do have a data lag while we wait for final data to come in, our lag is shorter. So we are able to publish 2019 final numbers in what we do, both in LODS and in the fact sheets that we publish. So like Karen said, this is hot off the press, brand new information. This information will be published in our updated death fact sheet that will be in several places on the LDH website. So here is the new opioid involved deaths in Louisiana by parish of injury. And opioid involved deaths is a really important distinction that we use in surveillance because it includes both the traditional overdose where the lethal drug ingestion is the primary cause of death, but also includes other deaths that are not marked as drug overdose, but where the coroner has determined that an opioid contributed to the death. So that this number is more inclusive of multiple causes of death than just the drug poisoning number. It is important for me to note here that opioid involved deaths in Louisiana have increased by 19% from 470 in 2018 to 563 in 2019. The gold bar represents a change or an enhancement that we made to the state's vital record system, which I'll talk about later in the presentation. We don't anticipate that the changes to the system are responsible for or explain the increase that we're seeing based on other numbers that match this increase in trend. But it is important for us to note that there was a change in the system at a point in time in 2018 and 2019. This is a new graph that we're doing this year that shows the increase in both drug overdose and opioid overdose deaths. We can see that both of these types of drug involved deaths are increasing. And the most important takeaway from this slide is that opioid involved deaths are continue to increase at a higher rate than all drug overdose deaths. So that is indicative of the rise in opioids and not being explained away by a rise in all drug overdose deaths. So we're seeing a smaller increase of all drug deaths, and of that smaller increase, there's a bigger increase in the opioid overdose deaths. This is a graph that we produce every year that shows the type of drugs, the type of opioid drugs used for these fatal drug overdoses. The lighter blue line at the bottom, I can we include it because it's important, but we don't see methadone deaths in a lethal amount. Typically, when we look at the toxicology for a methadone overdose, it was because the individual mixed methadone with other opioids, not because the methadone dosage was a lethal amount. I do always, when I do this, sorry, that was too early. When I do this presentation, I always draw attention to the dark navy line, which is the number, the increase in fentanyl deaths that we see from year to year. Drug deaths involving fentanyl, usually a fentanyl-laced drug, have increased by 1,400% since 2014, which is not out of line with what we're seeing nationally, but still a really alarming trend for Louisiana. You can see that it causes more deaths than heroin and opioid prescriptions in Louisiana. Heroin is the teal line, and natural and semi-synthetic, that's the opioid prescriptions in the lavender line under that. So this slide is to present to you the combination of drugs that we're seeing. So the dark navy at the bottom is just opioids alone. And you can see that that number this year has decreased slightly. The sort of aqua color is going to be non-stimulants. So that's going to be opioids along with most commonly benzodiazepines. And we also are seeing a lot of opioids with nerve pain inhibitors like gabapentin. And so there's been a sharp jump from 2018 to 2019 in those opioids in combo with non-stimulants. And then the gray above that is opioid used with a stimulant. And that number has increased by about 20% a year since 2016. And when we look at the toxicology for that opioid plus stimulant data, it is usually cocaine and heroin or methamphetamine and heroin in the toxicology reports. And the last thing that I want to highlight on this slide is that percentage at the top for unspecified drug deaths. So that's going to be a death where one specific drug was not listed or could not be determined as the drug that caused the death. We see a lot of these where coroners are certifying multi-drug toxicity or polydrug overdose because it was a combination of drugs that was lethal to the individual and not because toxicology could not determine that one drug was responsible for the death. So it's then part of our job in the surveillance program to understand this combination and types of the drugs that are being used most often in these unspecified drug deaths. We also have work to do with the coroners and with our user data, our performance data that we can do in Hillar to understand whether this unspecified drug death is increasing because people are decreasing because people are using better reporting, or if it's because the type of drug is more prevalent than it was in years before. Okay, now we're going to go on a little adventure. This is brand new. This is the first time we've done this slide, and I explained it a little bit to Karen before we started. Anecdotally, we have read about and been told about how the COVID pandemic has further fueled the drug crisis in this country, with people in isolation and being disconnected and not able to get to their services, and all of these being a trigger for substance use. We were recently asked by a national news outlet to provide data that they could use to analyze this. The problem with that is that it can take several months to certify a death as any type of poisoning because it requires the completion of both toxicology testing and forensics examinations. So the most recent data that we felt comfortable providing was June of 2020, and that data is still incomplete. Don't be fooled because the numbers are so much lower than the months before. It's because not all of the June deaths have been certified as drug related yet, but the trend is still visible. So each of these columns, I wish I could go and point them to you. Each of the columns is a month, and each month has 2 points. There's a 2019 point and a 2020 point. For each month, I keep doing that. So you can see, unfortunately, that the earlier months before the pandemic, we were seeing increases in all types of drug deaths. So the orange is going to be drug deaths, the green is opioid poisoning deaths, and the blue is synthetic opioid poisoning deaths. So we were seeing an uptick in comparing 2019 to 2020 before COVID, but then you can see starting in March when the pandemic hit, these numbers as much as double, a couple of them tripled during the pandemic. So March 22nd was when the stay-at-home order was signed, and then May 15th is when we moved into phase 1. So we're going to continue to get data in on this. We wanted to share this because we made it available for a publication, and it is valid and visual and supports the anecdotal information that we're getting from around the country. So I thought that our team thought that it was really important that we present this data today as we're having this conversation about how we move forward and what we need to do to target interventions and recovery and prevention and treatment in a post-COVID world.
Now, would you mind if we went back to that slide?
Yes.
And I had some additional time to absorb this earlier, but I just wanted to point out to people watching, first of all, I want to thank the Office of Public Health for releasing this for this summit, maybe a little earlier than they wanted, I'm not sure, but it's really special that we're getting to see this. But I just want to make sure people realize the gravity of what they're seeing in that presentation. I think they just flipped it off for a while, but if we could go back, just as an example, the April column, which is the 4th column. So just so I'm clear with what we're looking at, in 2019, there were, 86 deaths in April of last year? Drug-related deaths, not necessarily specific to opioid, but in April of this year, during the stay-at-home order, there were 55 deaths. And so we've all seen the headlines, the national headlines about the increase in overdose deaths during the pandemic and the stay-at-home orders. We have yet, other than outside of some localized areas, and we'll hear from District Attorney Moore, who does a really good job tracking this, and his team, but for Louisiana now, this is our data. For the first time, we are able to say those headlines that we see nationally are absolutely applicable here in Louisiana. We can see the data.
And we will continue to, I think every month, we will continue to update this as more data is certified and finalized. Currently there is no home for this graph. It doesn't have a spot on the fact sheets, and it's not in lots. So we will work with our Bureau of Media Communications and OBH to figure out where this information needs to go, because we definitely want people to see it and understand it. And I want to point out that the April and May fentanyl numbers, which is going to be that blue line, those numbers tripled, actually more than tripled from 2019 to 2020.
Great, thank you. I apologize for interrupting, but this was such an important slide, and takes just a second longer to digest as well.
Yes.
But it's no longer anecdotal for Louisiana. We now have the data.
Yes. We also have on logs hospital admissions involving drug poisoning and opioid poisoning by quarter. The trend here is typically that the first quarter of the year is higher, and then we see a drop until the 4th quarter, and then the 1st quarter gets higher again. this information does lack some drug specificity because it's based on claims information. So all of the diagnoses and all of the treatment modalities that are done may not be reflected in the claims data. Okay. So this is also a graph. This is actually some of the best news that we have in the state, and that is that our prescriptions per 100 individuals is going down. This is a result of the work that we have done, that the department has done and OBH has done with the Board of Pharmacy in utilization of the prescription monitoring program that requires that providers log into a system and look up a patient before providing an opioid. The PMP also tracks utilization, so they know whether providers are logging in or not, and they consistently work with the legislature to make sure that we have interoperability in the use of the PMP by providers, and then requiring as much as they can to continue to decrease the opioid prescription rate in Louisiana. So this is rewarding efforts that we can see in the data. We still have work to do to support the opioid response plan. Like I said earlier, we're expanding into the surveillance of all drugs. We look at what we're seeing is predominantly stimulants and benzodiazepines, but we're going to be looking at all of the drug combinations to see which ones are most prevalent in the state. We're really excited that we have a partnership with the Office of Behavioral Health to start tracking treatment data. So the question that we want to answer and be able to disseminate is, to what extent the persons misusing drugs are linked to opioid use disorder treatment and the type of treatment being used. We also have those additional data sources that I mentioned, the EMS data, the social determinants of health data that we're going to be adding to our analysis. And then we have a new partnership project to look at the role of public safety in a public health crisis. That's something that we're doing with the high intensity drug trafficking area and also the CDC Foundation. And so we're really excited for that project to get kicked off and start to see some results and some partnerships built from that. So this is some inside baseball for y'all. I wanted to highlight that 2 years ago, we were able to get enhanced surveillance legislation passed through the legislature that mandates some additional reporting and strongly encourages others. One of the things that we did was to work with the Coroners Association to put language in there about opioids being identified somewhere in the death record. We used some technology funds that we had from the CDC to actually put an enhancement of the state vital records registration system into for coroners to use. So the pop out right here is there is now the screen that you're looking at is the cause of death screen. So the immediate cause of death is going to be the primary cause of death. And then there are additional or contributing factors that can be listed in the death record. These are mostly used on the death certificate. And we know that coroner data is subjective and also sensitive. So to make it easier for us to work with coroners for our public health surveillance and also respect the sensitivities of the families that are affected by this, we added this radio button that asks the coroners to indicate if the death was drug related, were opioids present in the toxicology. So that is the button that went live in August of 2019. And we're in the process of doing our analysis to look at how coroners are using the button and how it's improving our data collection. We also are working with the Office of Behavioral Health on a project that they have, a legislative analysis on the distribution of MAT providers in the state. So this is a map that our team produced that shows the buprenorphine providers listed in the state's PMP. The darker the parish, the more concentrated the population. So you can see that our clusters are, as expected, around the more populated areas of the state. On that same effort, we also looked at the 10 OTPs and highlighted the communities or the parish area that is within a 30-mile radius of the OTPs. I believe that is also part of OBH's initiative to look at additional MAT options in the state. So I think we're going to have a different kind of question.
That's true. Now, I have two follow-up questions for you, and then we're going to allow all of our presenters to present, and if we have additional time at the end, we might take some questions from the virtual audience. But now, you, in one of your early slides in the LODS website, you had a beautiful map of Louisiana, and I'm not sure if we can get that's the one I was thinking of. I wanted to highlight this to the audience and talk about some ways the public can use this and see if you get lots of questions about this as well. So from the Office of Behavioral Health, we love this website and especially this feature because when we apply for grants and we're able to do some comparisons, look at regions specifically, and then we're able to copy it and plop it right into our grant application. Do you get a lot of people asking, can we use this information? Can we cite the website? Or if they don't ask, is that kind of the intent of the website and the data?
So we don't get a lot of people asking, but we know that a lot of people do use it.
Great.
Because it's out there and it's public, you can grab it, you can use it. We do tell people who do ask us for help in sort of understanding the data for grants that the counts are a lot less compelling sometimes than the rates are. So we are able to publish rates in LODS. And so that is allows your analysis and your presentation of your grant information to be a little more standard with each parish because it's calculated to match each region and each metric.
That's a really good piece of advice for those people now who know that this resource is out there and we encourage you to use it. I mean, I was just on it last week and was able to get some really great maps for some presentations to show that the state. The second thing I wanted to ask, and I wanted to make sure that I heard you right, fentanyl deaths have increased 1,400% since 2014. That was 1,400%.
Since 2014. Between 2014 and 2019, 1,400%.
In Louisiana.
In Louisiana.
Wow. And that's just staggering. And we may hear District Attorney Moore touch on that a little bit too. I'm not sure. But thank you so much. Now, do you have any closing remarks?
So because I did not put this in the presentation, but we do have, and again, my contact information along with a typo is on this last slide, but it looks normal at home. So my contact information is here. Our program also has some drug seizure information that we get from the DEA, and so we do have that in a visualization and available. Also, any of the data that I have presented here, we can provide to anybody in a PowerPoint format. We just ask that the proper citation and source information is used.
Absolutely.
Thank you so much.
Thank you, Nell,
for letting us come and present our work, and we appreciate every time that we get to come and be involved in this conversation. We have become very impassioned in this work, in the data collection process, so we are grateful for the partnership and the opportunity to present what we do.
Yeah. Well, thank you for your expertise. Thank you. I love people who can be passionate about data because the rest of us need you. So thank you so much. So with that, we are going to take just a second and transition to our next panelist. We are using new microphones for everyone, so I think we need to just 1 second to switch out. And in the meantime, I'll ask District Attorney Hillar Moore to step up along with his second section chief, Steve Danielson. We've got 2 microphones. I will say I am going to put on a mask because we've specifically spaced out our 6 feet because you and I are going to be a little closer to each other. But I think that should be fine because I'm not going to speak. I'm so honored that y'all have been able to take time out of your day to come and present. We have 1,000 registrants for our summit located all over the state, maybe even a few outside of the state. So your message is going to be heard far and wide. I think it's really important to get this local perspective. I know you guys are doing some really sophisticated things on a local level, and I think it'll tie in nicely from what I've heard you talk about before with how Nell presented on the statewide perspective. So we're going to get you a fresh mic there, and I'm going to hand off to you.
Sure, it's a pleasure to be here. It's unfortunate that we are here, particularly as a district attorney, to have to talk about this epidemic that we're having in our country and now for us, particularly in Baton Rouge. But I want to compliment Dell. That was an awesome presentation. And the data that you presented just really fits in hand with what we see on a level here in Baton Rouge, and it's not a good sight to see. So to take you back a while, several years ago, I want to say it's 2014 or so, we were really alarmed at the number of heroin-related deaths that we were seeing. It was around 20 a year or so, if I'm not, maybe not that accurate on the number, but it was a lot. We're seeing a lot. And so we talked to the legislature about maybe changing some of the laws then. And that was in conjunction with the state police and the crime lab and then the coroners. And then from there, every year, that number is just staggeringly risen, and to where we are at a place right now where we do not want to be. And we need to find a way out of here. And as law enforcement knows, we are not going to arrest our way out of this situation for use of drugs. This is a public health crisis situation. It does have a law enforcement component, but we're mindful of our position in this. So as you know, opioids have been just overprescribed for many, many years. And then eventually PMP program came in, and that really helped a lot. The problem is, which has left us with, is now since the regular prescription opioids are so hard to get for those that need it or for legitimate reasons, those that for illegitimate reasons that take it, that are not prescribed, now the market, the illegal drug market has now thrived on that need. And we have now seen where opioids were around 40% cause of the death of drug overdoses. Now fentanyl has weaponized heroin and drugs, and we're seeing those numbers just increase in alarming type of rates. So this is something that's been on our mind and that we've been looking at. In Baton Rouge, as DAs and in law enforcement, you guys know we look at homicides and murders and non-fatal shootings that tell us how is your city doing with regard to violence. Baton Rouge does not have a particularly bad crime problem. We do have a murder problem for the city our size. And I only say that to put in perspective kind of where we are now with heroin and opioid related deaths. So this year, at this point, we're around 70 murders or so in Baton Rouge. Last year in 2019, we had 120 heroin opioid related, fentanyl related deaths compared to the number of homicides we have. This year, unfortunately, we're at the level, now we're at halfway mark through the year, a little bit further. We will see a doubling of last year's heroin opioid fentanyl related deaths to probably around the tune of 240 people losing their life to this drug. And that just puts it in perspective for us that we see and we fight every day. And it's always publicized about the homicide rate, but this rate, this overdose rate is enormous. It's alarming, and it's one that we need to take attention to, pay attention to. And I'm glad to see that everyone's doing that. In the past, however, past few years, we have not really been together. We all worked in somewhat silos and not known what each other is doing. We in Baton Rouge were fortunate to obtain a Bureau of Justice grant. It's an innovative prosecution grant, where as a DA's office, we want to look at not only overdoses and deaths with this, but we also want to know who are the drug dealers? Where's the heroin coming from? Who's dying from this? Is there a potential criminal case? But again, remembering that we do not want to arrest. We want to help those that are users and abusers, but we want to find out where are you getting this from so that we can maybe put an end to that. So we've been working in conjunction with LSU and the Social Research and Evaluation Center, SHREC, and we are in the process of now presenting a paper, The Criminal Justice Response to the Opioid Crisis in East Baton Rouge Parish, Current Actions and Future Considerations. We're in the draft of this now. It's a well thought out paper, well-written paper. And before I turn it over to Steve Danielson, who runs the Crime Strategies Unit, that is really the unit that looks at all of the details. They have the finger on the pulse of overdoses with the assistance of the National Guard. We're fortunate in Baton Rouge to have a cooperation endeavor with the National Guard, counter drug intelligence analysts that have done a phenomenal job for us, along with the coroner's office and all the other agencies that Steve can talk about. But having gone through the data now for 2 years, the points of the recommendations that we're going to make for Baton Rouge and try to put these into place are strengthen the community partnerships to expand access points, expand prescription medication disposal programs, expand community education efforts, support the expansion of effective treatment and harm reduction efforts, publicize the Good Samaritan laws, bolster prevention efforts, implement departmental protocols regarding possession and use, utilize federal law enforcement levers, identify and monitor social network using social media data, develop a forensic certification-based collegiate intern program, provide appropriate referrals to drug court, establish a prison take-home naloxone system, establish a leave behind the naloxone program, and provide insight regarding overdose hotspots. So Steve can tell you in Baton Rouge what we are seeing with regard to these particular drugs, since he does this on a regular basis. So Steve, you give an idea of Baton Rouge particularly.
So in Baton Rouge, the overdose deaths are out of hand. I was surprised to see that our increase in fentanyl-related deaths was 1,400, I think, % increase. And I suppose one of the challenges we face as law enforcement, as prosecutors in partnership with our law enforcement agencies, is trying to find out how this is happening and what we can do to try to put a stop to it. When we look at the data, we don't see too many really individual hotspots, or we've not seen a traditional, spike, if you will, where some dealer who sells a brand of narcotics that results in a series of deaths that you can kind of spiderweb back toward the dealer for prosecution. We're actually seeing it spread out fairly wide throughout the parish. However, we do see some areas that are traditional in causing us problems. I think we see it with some hotel and motels that have an excessive use of narcotics and therefore an excessive use of overdose. We also see it, unfortunately, we see some deaths at rehabs and sober living facilities and halfway houses and three-quarter houses. And in those kind of situations, what we try to do is try to identify the person that is preying upon the people in recovery, or the person that is preying on the people in the hotels and motels. And so, as Hillar said, we're not trying to identify and prosecute addicts who share narcotics, with their partners or their friends. But what we are trying to do is trying to identify the people who make a conscious financial business decision to engage in the distribution of narcotics, especially heroin laced with fentanyl, and try to find ways to target them. And one of the most productive ways we've discovered, of course, is that with our law enforcement partners, having them kind of step up their investigation step up their investigation of all overdose scenes. And so you'll have overdose scenes that are fatal. You'll have overdose scenes that are not fatal. The fatal ones are obviously the easiest ones for our law enforcement partners to investigate. And we're seeing our law enforcement people here in East Baton Rouge Parish start to investigate those as if they were traditional murder scenes, crime scenes, if you will. And so they will interview the people that were there. They will collect evidence. They will see cell phones. And the cell phone aspect is just invaluable for us. Our law enforcement partners have the technology to a degree to download cell phones. However, we're kind of hamstrung by the fact that that technology is employed mostly for murders and in cases like that, and not so much with the overdoses. And the overdoses are a kind of a wave of cases. So we're looking for ways in which to help them facilitate the forensic downloading of these phones to gather information. And what we find when we do that is that typically the deceased person whose cell phone we've forensically downloaded typically their last contact in this situation is going to be with the person that was their dealer. And we have cases where you can just see the phone number 1, 2, 3, 4, 5, 6, 7 multiple times as they arrange for the transaction that ends up causing their demise. And so we gather that information, we compare it to other overdose thefts. Sometimes we will find, in some cases we'll find that the dealers have common overdose victims. And when we find that sort of situation, we will expend a lot of law enforcement effort in trying to, properly identify that person and then trying to establish a case so that we can then get that person arrested and brought into the system and prosecute that person accordingly. But it is a challenge. We work very well with our U.S. Attorney's Office. The federal law provides for situations wherein if somebody is convicted of a distribution of a narcotic that has resulted in serious bodily injury or death, there are sentencing enhancement provisions in federal court that are a very helpful tool for us as far as leveraging the removal of dealers from our community. But I don't think we see the drugs being distributed in the way you may have seen it back in the 80s and 90s when we had crack cocaine, where there were open air markets, there were dealers on the street. This challenge this epidemic presents different challenges in trying to really identify people who, unfortunately, if you're savvy enough, if you want to, you can go into the dark web. And I've been in the dark web just a few times, but it's amazing and almost horrific to see how much and how easy it is to obtain some of these drugs, and then having purchased online in a somewhat clandestine way, have them delivered in a very anonymous way, and then having them sent out. It sort of belies the old traditional distribution models that we would see with cocaine and marijuana back in the day, although those lines still exist. But as we go forward, one of the things that we do want to do is educate our community and stress to them that we do in Louisiana have the Good Samaritan Law, which is Louisiana Revised Statute 14:403, I believe. And that statute essentially provides that if you're with somebody who's experiencing an overdose and you call for assistance, you will be cloaked with immunity so that you won't be arrested, you won't be prosecuted, because you did the right thing. You sought help for the person who's experiencing the overdose. And it's a good thing. I just don't know how well it's been communicated across our parish so that everybody knows. Here in East Baton Rouge Parish, of course, we have a community college and 2 other universities. And so we have a lot of young people who I think really need to know that, calling for help in that sort of situation is what needs to be done, and not being fearful of your own criminal responsibilities is really important.
So Steve, it looks like the data that I've seen with you is that in the past we had a drug dealer that generally dealt cocaine or heroin, but it seems like now when we find people who are dealing drugs, they're dealing everything, including heroin, in maybe smaller amounts, but the heroin dealers are all over. And for what you've just informed these people is that we're also now having to fight distribution of these drugs by mail or by delivery by regular people that have no idea that they're delivering a very harmful substance.
Correct. One of the really, I guess, scary developments that we had noticed and that the data supports, I suppose, is fentanyl is making its way. Fentanyl and carfentanil are making their way into not just heroin anymore. They're making their way into cocaine. They're making their way into pills. We're recovering from dealers' pill pressing devices that they use in order to produce counterfeit pills that they in turn sell. However, some of those pills are going to contain fentanyl, and that's a scary thing. And for a person who's suffering from an addiction, who may know that they can take 2 or 3 Loratabs or whatever their drug of choice is, now they're presented with a situation where they know those pills may be laced with fentanyl, in which case 2 or 3 is going to be a lethal dose, and that's disturbing. Cocaine, if you cut your cocaine with fentanyl, again, that's a danger that you may not know exists as a substance abuser.
So if you don't mind, may I ask, Mr. Danielson, you had mentioned a reference to purchasing on the dark web. Do you think that has contributed to the increase in fentanyl overdoses or deaths because you really don't know what you're getting, and then there's not a person, you used to hear about people developing that relationship with their drug dealer, but when it's on the internet, you might not know what you're getting.
Yeah, and it seems to me that in my limited forays into the dark web, there's a desire to be somewhat truthful and to have good customer reviews, as funny as it sounds.
A Yelp for...
Yeah, so you can buy fentanyl in the dark web, and they will, guarantee it's fentanyl to the degree they can, and that's kind of the scary thing. There seems to be a level of honesty in what you can purchase there. It's just scary that now anybody with a computer and the knowledge to get into the dark web can do it. And we have not found a successful way to track the level of transactions that occur at that in that environment, because that's beyond what our capabilities are. But it just seems as if any enterprising college student could do it if they chose to do so, and that's very disconcerting.
What about fentanyl test strips? You hear about those.
So I think that's one of the recommendations that Hillar had referenced. They're supposedly, I think they're very inexpensive and very reliable, and they are helpful to a person who does engage in an illicit transaction, and they want to be sure before they end up overdosing exactly what they have. And the fentanyl test strip will at least give them a heads up as to, okay, if I wanted pure cocaine or just heroin, now I know this is laced with something more, and maybe I want to take
Form of harm reduction.
So Steve, maybe can you talk about a scarier situation where you and your team have found that people who are using and abusing heroin and fentanyl, that they do want the drug that is the most powerful to the point that they will not die, and that's a very scary situation that we see.
So for me, going to some of the intensive outpatient treatment programs, listening to some survivors talk, I was struck by the fact that in those conversations, when the person is just kind of letting down their guard and you're not in your law enforcement capacity or anything, they'll talk and they'll tell you in almost in a bragging kind of way, I've died 3 times. And they'll explain what they mean by that is that they've overdosed and been hit with Narcan and come back to life, overdosed, hit with Narcan, come back to life. And it struck me as it was almost cavalier the way they discussed it. But what we also would find was that the dealers knew that their customers wanted the best high possible. And one of the best ways to get it would be to cut your product with fentanyl. And we would see people who would then go to that dealer, purchase that product, overdose. Word would get out of their overdose. And some of the people in the throes of addiction would then kind of start thinking to themselves, well, that person was weak. They don't know what they're doing. They don't have as much tolerance. This stuff has got to be good. I'm going to go try it myself. It won't kill me. I'm a survivor. I'm Superman. I'm untouchable. And they'll go buy a product that has just killed 1 or 2 people, thinking that it's got to be a great high, as opposed to realizing this could be trouble.
Great. I I'm sorry, I'll let you finish. We've got a few questions coming in, but I'll let you guys finish.
One
your
of the
presentation.
things when we're talking about making these cases of the people who have died overdose to try to find the dealer, it's easier said than done. It's very difficult, hard work, because you do have someone that used that wanted to use, so we have to deal with that. But it's very difficult, tedious work that we're working on. Again, we're trying to stop the person from dying from in the beginning. But one of the problems that we face is data and data collection because of HIPAA. What can EMS give to us? They can't share a name. What can the hospital share with us? Can't tell us name. Can you maybe tell us where it happened, where they came from, so we can use that data to maybe put that together? So that's one of the issues that we faced. Also with the Good Samaritan and Narcan, when folks are brought back to life, in the past prior to that, I'm not saying this is a bad thing, it's a good thing, we're saving lives. We would then be able to obtain that person's cell phone and get that last number. Now that's all pretty much gone. So that data that we would have is now not there, which is, again, a good thing in a lot of regards. So that's one of the things that we are fighting now. But data collection is huge. And also just the increase in the number of hospital emergency room visits from opioids and fentanyl, just like violent crime. If we could really focus on that, well, we'd really be doing a really good service to the community. And that's where part of this grant is taking us.
Great. So let me ask you, I kind of introduced you as a district attorney's office that is pretty progressive and has a real heightened focus around this area of your kind of business. What could we do to encourage other law enforcement agencies or district attorney's offices to take the interest you do? Are there, is there any way that treatment community can help, or is there any kind of grant opportunities you would advertise to your fellow DAs and law enforcement? I know you are a tight community to begin with the district attorney's offices across the state and your association.
We do have a really good relationship in Baton Rouge with all the law enforcement agencies, the mayor, our representatives and senators. But I've been fortunate to travel around the country and meet with the funders, these programs, and just seeing the numbers in Baton Rouge. We were excited about the chance to look at this, but also we're also fortunate to have a crime strategies unit, which is an intelligence-driven prosecution unit, really focuses on violent crime, but also fit in with this. So that's really how we were able to get this. This is a heavy, heavy lift. We've been working on this just the data-wise for 2 years. So this is not something you just easily pick up and run with, and many officers cannot fund it. It's very difficult for us to fund what we do, so we do rely on these grants, and it's really now good to know all of the other people and organizations in Louisiana that are fighting the same fight, that we all get together, and because we just can't have 240 people die of this. This is a public health crisis, emergency. It's not a law enforcement issue. It has some portions of that. We have to find a way to save our citizens.
And because you're doing such a heavy lift, hopefully you can kind of blaze a path and make it easier for smaller district attorney's offices, people with fewer resources or ability to kind of make it easier for them to kind of learn from what you've done. I want to ask a little bit more, building on, you talked about the Good Samaritan Law. We've talked a lot about naloxone and Narcan. It's part of the plan that you have presented. It's also one of the pillars that the state's opioid plan with intervention. We have tried to encourage kind of non-traditional entities to carry naloxone and Narcan. Is that something you also encourage? I think for a long time it was, if you're in the substance use field, you carry it, but we're finding, it's people don't typically overdose in their provider's office. They're in the community, they're at their neighbor's house, they're on campus, they're it's people you go to church with, other people that really need to have it. Do you have any thoughts on that or opinions about maybe even expand a little bit about the Good Samaritan Law and how it applies to everyone, not just people in this industry, kind of?
With regard to the naloxone and the other efforts, so we were proposing that this be community-based wide distribution. So again, your non-traditional people that would have it and distribute it, we're now saying let's take a better look and a wider look at who we should give this to. and have it available to distribute to them.
Yeah.
Steve, on the Good Samaritan.
And you also have the leave behind concept too, which I think was, a very great concept where if somebody overdoses and survives, allow law enforcement or EMS to leave behind some of the Narcan or Naloxone so that they can, hopefully, not have the same experience again.
I think one of the things Steve touched on earlier was that we have found that a good portion of our people that are overdosing and dying are leaving the prison, and they dying within 2 weeks of leaving the prison. So can we identify who our users are, who are potentially who's going to die? And we've found that that's going to probably be for sure at the Parish prison. Can we find out what they're being brought in for? It's generally drugs and heroin. And can we get them an exit interview to talk to them about this? Can we give them advice? Can we give them this medicine to take with them? And again, as Steve mentioned, those that are in the halfway houses, three-quarter houses, we see a lot of people that are dying there. What can we do for those people that are surely highly at risk? So I think that we're able to look at some of these efforts and direct our focus there.
Yeah, it just makes sense. Just needed data to kind of highlight that. It really does. Anything else you guys would like to touch on?
We've just been struck with the enormity of the situation, and this kind of fits in with everything. Law enforcement always gets tagged with taking care of things in our community, our nation, that are not funded properly. Surely this is one of them. It's drugs and drug overdoses. This is not just a law enforcement situation. It's a minor law enforcement situation. It's a public health crisis that everyone has to be aware of. We have seen how it's cut across our entire parish, where we normally have particular people that are overdosing in certain areas. You can throw that model out. It's all over East Baton Rouge Parish. It's not your traditional drug dealer now or drug user. And so this is really taking the cloak off of this type of drug use, and unfortunately it's awakened a lot of people.
Yeah. Well, thank you. Thank you for your work. We might open it up and see if we have a few questions. If you wouldn't mind, if you have some time to hang around, that would be great. We really appreciate it.
Sure.
Thank you. Pam, we don't have any questions that have come in yet. So. All right, so at this point, gentlemen, if you'd like to put your mics down and we will get those collected and replaced. At this point, we'll move to our third panelist. It's my pleasure to introduce Dr. Rochelle Dunham, who is the Executive Director of the Metropolitan Human Service District, who is our boots on the ground behavioral health provider in the greater New Orleans area, serving, I believe it's Plaquemine, St. Bernard, and Orleans parishes. So I can take this off. She is joining us through Zoom. Metropolitan has taken it has a large responsibility in the response efforts for Hurricane Laura with the numerous evacuees that are in New Orleans at this point. And so she is in the midst of also addressing that crisis in New Orleans, as well as most of the southern part of the state. So she was not able to drive to Baton Rouge today because they are in 24-hour emergency response mode in the Orleans area. So she has joined us through Zoom. I believe so at this point, I'm going to hand off to her and allow her to do her presentation.
Hey, good morning, Karen. Can you hear me okay?
I'm Dr. Dunham.
Good morning. It is my pleasure to be a part of this esteemed group. In my world of addiction, I'm just delighted to hear so much conversation about substance use disorders, because for many, many years as an addictionologist, I felt like one of the few lone rangers crying out in the darkness, please, we've got to look at addiction. We've got to pay attention to it. It is part of the very fabric of what's happening in our world. And if we don't pay attention to it, it will overwhelm and overcome us. And we are exactly there. We have had epidemic moments throughout the course of history where different substances predominated in terms of the impact it has had on communities. Right now, we are experiencing the opioid epidemic, but we have had epidemic issues with different drugs over the course of many decades. Death due to substance use is a different conversation, and certainly we need to pay tremendous attention to all the data that has been presented so far. So my title is Managing the Opioid Epidemic During COVID-19 and somewhat of a local perspective. So what I'd like to do is to share a summary of opinions from the National Institute of Health, Michigan Department of Psychiatry, Harvard Medical School, specific to where these things are converging, because we are at a very unique place in our history where we have two very, very deadly scenarios converging. And so relevant subject matter for this conversation, in addition, it is the additional impact of the hurricane season on both epidemics and the challenge it lends to the conversation in both situations. So what I'll say as a preemptive statement is that I'm reminded of the wisdom of the first step of the 12 steps of recovery, which speaks to a belief in a power greater than yourself. And the wisdom of that statement to people in recovery has everything to do with the fact that we as human beings will encounter scenarios in our lives where we are exceeded in terms of our capability to overcome it or make it change or go away. And we are at that very point. We are always behind the 8 ball, it seems, with addiction, and we are certainly scurrying behind the 8 ball, trying to get ahead of this COVID-19 pandemic. But there is knowledge and wisdom when you can have a belief in something bigger than yourself, being able to mask what's going on. And so I am grateful to the developers of all of the 12 steps, and particularly the first one, which speaks to a belief in something bigger than yourself. So COVID-19 and the opioid addiction, unfortunately, are two great epidemics, as I've said, of our generation, intersecting and colliding in ways that are additively deadly, and which highlight the urgent ways we must respond. Several issues require consideration, each of which impact and worsen both crises. So what does the science tell us? Much remains to be learned about COVID-19, including how it affects people who smoke or vape or who have a substance use disorder. However, it is known that these individuals are more likely to have suppressed immune systems, are at greater risk for respiratory infections, and may have lung and heart diseases. This could present a greater risk for COVID-19 infection or more serious causes of the disease, which is why this is such a dangerous time we're in right now. During these uncertain times, those who misuse or abuse alcohol and other drugs are particularly vulnerable. The stress from social isolation and other COVID-19 related changes can lead to a worsened substance use and misuse, as has been alluded to and as we are seeing. So for alcohol, first of all, which is the second most commonly used substance of dependence, alcohol consumption weakens the immune system and can increase the susceptibility to certain infectious diseases, all of which predispose to harsher, potentially more deadly courses if the person contracts the coronavirus. For individuals who are dependent on alcohol, restricted access to treatment often results in symptoms of withdrawal, as we know. And an alcohol withdrawal can be fatal in 5% of the time if it is not detected and treated. For cocaine, which is the #1 cause of death from substance use by the underserved minority communities for many decades, smoking or snorting cocaine causes changes in the brain that result in constriction within the vascular system, the arteries, the veins, the capillaries, and can lead to severe damage of lung and respiratory systems. Smoking cocaine can lead to many complications to the lungs, such as swelling, hemorrhaging, pulmonary edema, bronchitis, asthma, and emphysema, all of which in the setting of COVID is a problem. For methamphetamines, which was epidemic about 10 years ago and is now increasing the numbers related to opioid-laced products, methamphetamine use is particularly dangerous as well in constricting blood vessels, which can lead to pulmonary changes and hypertension. Additionally, blood clots are causal in many cases for increased morbidity and mortality in the coronavirus deaths. For opioids, which we're spending a lot of time with today, because opioids negatively impact lung and heart health, people who use opioids at high dosages may be more susceptible to COVID-19, and the illnesses may be more severe. People who have an opioid use disorder also face separate challenges to their respiratory health. The pharmacology of opioids results in direct impairment of the respiratory center of the brain, the center of breathing. Opioids exert effects at the brainstem to slow breathing, which not only puts the user at risk of life-threatening or fatal overdose, but it may also cause a harmful decrease in oxygen in the blood, which is called hypoxemia. While brain cells can function for short periods of low oxygen, longer periods with low or no oxygen can be especially damaging to the brain function. Chronic respiratory disease can increase deadly overdose risks among people taking opioids, and diminished lung capacity from COVID-19 could similarly endanger this group. So one of the things that I want to share with you is data that has been collected regarding naloxone in the New Orleans area, and it's a composite of data from the New Orleans Emergency Medical Services, or EMS, fire and police departments. And what they show is naloxone, we know, is particularly important for us to, it's an indirect measure of substance use, particularly opioid use, because the administration of naloxone as an emergency rescue medication is predominantly the life-saving measure that has been adopted, and infers an indirect way of measuring whether people actually have had opioid use on board. So recent trends in the past 3 years, July 2017 through June 2020, which is about 36 months, the number of EMS naloxone administration calls with evidence of opioid use increased substantially. Now, this is consistent with the data that Nell showed you all. It has increased at an average rate of 10.6% in the New Orleans area. Further review of the data points indicates that naloxone administrations with evidence of opioid use decreased during 2018 and most of 2019. I think that had a lot to do with the prescriptive changes that we made, where we saw roughly a 25% reduction in prescriptions that were being authorized by physicians. So changing those prescribing practices probably has had the most significant impact on opioid deaths. And so during the period of 2018 and most of 2019, where those numbers decreased, it's probably owing to the change in circulating opioids in communities. But it increased dramatically beginning in August of last year, again, 2019. So for the past 12 months, July 2019 through June 2020, New Orleans Emergency Medical Services and the fire police departments administered naloxone to 1,424 patients on service calls. Post-administration assessments indicated that there were 1,374 naloxone administrations with evidence of opioid use, including 58 cases of opioid cardiac arrest, 719 cases of admitted opioid use, and 597 of suspected opioid use. So the total naloxone administrations with evidence of opioid use from July 2019 through June 2020 increased 45% from the 950 cases in the previous 12 months. So once again, the trend data is consistent. What we are sharing with you all are different ways that we're slicing this pie, and the pieces all taste the same, and they're coming out about the same in terms of the impact of this condition on our communities. I've talked with you about some of the substances and the impact that it has on the brain and the body that makes the collision course between addiction and COVID particularly frightening and damaging. But let's not forget smoking and vaping, which includes marijuana. Nicotine remains the #1 substance of dependence, and smoking also remains the #1 cause or associated cause for the top 5 most common causes of death. Many times when we talk about substance use, we really don't talk enough about alcohol use and smoking or tobacco use because they are legal substances. The irony, however, is that they are the #1 and #2 top preventable causes of death that require really, really aggressive treatment. And certainly smoking is a lung-aided practice. And so the smoking increases the risk of COVID complexity in 14% of cases. So we know that cigarette smoking suppresses the immune system. It increases the risk of respiratory infections, including pneumonia, and it causes heart and lung diseases. This puts people who smoke cigarettes at an even greater risk of contracting COVID, resulting in more severe infections in 14% of cases. We know that when you smoke or vape, either tobacco or marijuana, you are at increased risk for health consequences such as cancer and lung damage. In addition to smoking, emerging evidence suggests that vaping causes damage to lung cells, cells in the lung, and inflammation to lung tissue by exposing it to toxic chemicals. This reduces the ability of the lungs to respond to infection and clearly to move air. Because the coronavirus is lung-centered, it is debilitating to the body. Smoking, nicotine and marijuana, and vaping may pose serious risks to those who contract the coronavirus. Finally, the co-occurrence of mental illness and addiction also is worthy of mention because often, in over 50% of cases, people are experiencing core mental health issues that are diagnoses that require interventions and treatment in order for them to get well, in addition to substance use disorders, which may or may not be, drugs and alcohol may or may not be used to treat symptoms of the mental illness. They may be precipitated by the mental illness. They may be a completely separate process going on in isolation of the mental illness. But people with addiction have depression, anxiety, and other mental concerns during COVID. The constant flow of stressful news frequently leads to increased feelings of worry, anxiety, and stress. We know this well. The resultant persistently high levels of the body circulating cortisol levels, the fight or flight stress hormone meant to elevate for brief periods where survival is threatened is now persistently elevated and a major cause for persistent hypertension that is not easily controlled by medications. The social condition of addiction predisposes to uncertainty and stress alone. Coupled with COVID-19, the physical and emotional damage is tremendously intensified. It is imperative that the presence of mental illness and substance use disorders are both treated as primary, and that priority is given to alleviating stress, anxiety, and depression. Those things are killers under the circumstance. The combination of social, emotional, spiritual supports, along with cognitive, behavioral, and medication supports are even more critical elements in the formula for health in the setting of addiction and the coronavirus pandemic. So again, COVID-19 and opioid addiction can impact and worsen each other. COVID-19 and any substance use disorder can impact and worsen each other. The complexity there is that most of the time people are using multiple substances. And so even though I'm sharing with you what has happened or what happens with individual substances and their impact to a brain and body tissue, most of the time people are using several substances at the same time. So do the math in terms of the additive effects of that. And now we have two great epidemics of our generation intersecting in ways that are additively deadly, once again, and which highlight the urgent ways we must respond. So there are several issues that require consideration each of which can worsen the course of these two major factors. The first thing is social determinants of health create greater vulnerability. People who suffer from the disease of addiction are particularly vulnerable to both contracting the coronavirus and having a more severe disease when they do contract it. There are many reasons for this, many of which I've itemized for you relative to specific drugs. But what it boils down to also is the complexity of the social determinants of health, which according to the CDC are conditions in the places where people live, learn, work, and play that affect a wide range of health risks and outcomes. In short, people suffering from addiction are vastly more vulnerable to coronavirus, as they are more likely to be homeless, to be poor, to be smokers with lung or cardiovascular disease, to be under or uninsured, or have experienced serious health and socioeconomic issues from drug addiction. There are also millions of vulnerable incarcerated people, many of whom are stuck in jails due to their addictions and related nonviolent drug offenses. The second reason why this collision course is so deadly is because treatments and support systems are disrupted. For someone struggling with addiction, virtually all of the services and treatments available to them have been disrupted by the COVID-19 pandemic. People are told to stay home, which directly contradicts the need to go to clinics to obtain methadone or other medications or other services for treating addiction. Our government, in response, has relaxed regulations so that, in theory, clinics can give 14-day or even 28-day supplies to stable patients so that they don't have to wait in line and can adhere to social distancing for safety. Unfortunately, there are countless stories of patients not being granted this privilege. Similarly, the government has relaxed some restrictions on buprenorphine prescribing and has allowed some telephone prescribing, but this presupposes that there are doctors available that are healthy and certified to prescribe this medication, and that the pharmacies and doctors' offices are functioning. Access to clean needles is affected as well. Additionally, many rehab facilities have limited new admissions, canceled programs, or even shut their doors for fear of spreading coronavirus in a communal living setting. The third complication, which makes this a collision course that's deadly, is social isolation, which increases the risk for addiction. A common truism in recovery culture is that addiction is a disease of isolation. It really is. So it stands to reason that social distancing in every possible way is counter to most efforts to engage in a recovery community. It is important to remember that experts distinguish between physical distancing and social distancing, and actually emphasize that we keep physical distance, but we make extra efforts to obtain social bonds during this time of enormous stress and dislocation. The social isolation that is so critical to preventing the spread of coronavirus prevents people from attending peer groups, which are such a vital source of emotional and spiritual support to people struggling to stay in recovery. The fourth impact to the collision course is isolation may increase the risk of overdose deaths. You've heard some of this already as well. Heightened anxiety is a near universal trigger for drug use, and it is difficult to think of a more stressful event for all of us than this pandemic. Users who adopted harm reduction techniques and had been using drugs with a friend are now using them alone, and there's no one nearby who could administer naloxone or call 911 in the event of an overdose. As a consequence, police have been finding people dead in their apartments, dead in alleys, homeless people dead on the streets. When people do call 911, the healthcare system is overloaded and first responders may arrive more slowly. We know that starting addiction treatment in the ED or the emergency department can help prevent relapse, but right now emergency room doctors are absolutely overwhelmed with COVID-19 cases and might not have the time or resources available to start addiction medications following an overdose. Increased burden on emergency departments from COVID-19 may mean that people presenting with opioid overdose are less likely to be initiated on medication therapies, which is an important part of lessening the effects of the opioid crisis. Possibly, lack of access to medications for treating opioid use disorder may increase the likelihood of relapses and opioid overdoses. Due to physical distancing, many people with opioid use disorder may not have a family member or friend with them to give naloxone in the event of an overdose, resulting in more fatalities. Sadly, the ugly face of stigma and discrimination remain in the midst, as there are reports surfacing of police departments across the country that are refusing to offer naloxone to patients who have overdosed on the pretext that it is too dangerous because the addict, in quotation mark, might wake up coughing and sneezing coronavirus droplets. Now, of course, that's not happening in the state of Louisiana, right? Okay, so the fifth contributor to why this is a highly dangerous collision course we're on is multiple health crisis means comprehensive solutions, which we may not always have. What we need to do now is reach out more than ever to those who are struggling with addiction and provide them with the resources such as online meetings so that they are not alone and forgotten during this dual crisis of coronavirus and addiction. We need to make sure that they're getting medications they need to recover, that they have access to clean needles if they are still using, adequate medical care, food and housing, basic human needs. If any good has come out of the misery of the combined COVID-19 and opioid epidemics, perhaps it is that a clear, bright light has been shown on the deadly social fissures, poverty, income inequality, lack of health insurance and access to health care, homelessness, and the global impact of racial disparities on all of the named factors, which are all the true social determinants of health we will need to address as part of an effective response to future pandemics. So I want to shift to what we're doing in Metropolitan in the greater New Orleans area. Just to give you a little bit of background in terms of our demographics at Metropolitan, 86% of our residents reside in Orleans Parish. We are the district that serves Orleans, St. Bernard, and Plaquemines parishes, but 86% of our residents do reside in Orleans Parish. That is not a reason to not prioritize the other two parishes. In fact, generally what we do, we provide a similar emphasis on services for the other two parishes that is culturally appropriate. Of all persons served ages 0 to 65, 20% of our population is youth under the age of 21, and 80% are adults. The top two diagnoses for substance use disorders are opioid use and marijuana use, both at the severe rating of degree of impairment. Our top child and youth substance use diagnoses is marijuana, mild, moderate, and mild and moderate use predominantly. For mental health, mental illness in adults, the top two diagnoses are schizoaffective disorder and chronic paranoid schizophrenia. And then for child and youth, two mental illnesses are ADHD and PTSD. So local efforts in the greater New Orleans area, inclusive of all three parishes, have included nearly 85% of our services are delivered via virtual or telehealth platforms. We are grateful for CMS's decision to approve payment for coding for behavioral health services via all telehealth for all behavioral health providers, because prior to now, psychiatrists primarily were approved and APRNs But now our clinicians who are licensed staff, LCSWs, LACs, LPCs, can also bill for services. And we appreciate all the work that the state has done working with CMS to make sure that we have been able to utilize this payment method. As such, though, 50% of our services are via audio calls, which makes this even more important because traditionally audio calls are not the mainstay of psychiatric care via teleplatforms for obvious reasons. But under the circumstances, and particularly in our population, it's important that we're able to use audio as a billable service because many of our persons who we serve do not have access to the internet. Many of them don't even have a smartphone. So people are able to do FaceTiming as well as doing audio calls if necessary in order to maintain continuity of care. So 50% of the telework we're doing is using audio. 30% is video calls. And we still have about 20% of the persons who we serve walking into our clinics for services. And that's mainly people who require services that have to be done in person, like medication injections. If it is an urgent or emergent need, they're told to come into the clinic. Our aftercare population transitioning from the hospital into services, it's important that they come into the clinic at least for that first visit. And then we allow physician discretion in terms of who else needs to come into the clinic. We have surveyed our population as well as our providers to get a pulse on their reaction to the teleservices we're providing. And in both cases, they've rated it very high in terms of satisfaction with using that as a modality of care. Our persons who we serve have also expressed concerns about coming into the clinic as much as it has been a concern for us keeping our environment safe. So the teleplatform, as is the case around the state as well as in around the world, has been tremendously life-saving for the work that we do that is so critical to people's health and mental health. In Metropolitan, marketing has been a huge priority as we strongly believe that the services we provide within the public system of care are stellar and should be showcased for each of our community residents to access. How will they know if we don't put it out there that we're providing these services? So a variety of mediums are used at Metropolitan, such as social media, radio, television, local print, to name a few. Commercials specific to work and the impact of our services by peers or on peers. Our telehealth services and our medication-assisted treatment services have all been featured commercials in our area. So marketing is woven into the very fabric of what we do because we believe strongly that everything that we do needs to be known so that it can help somebody who may need us. MHSD also launched this OBOT, Office-Based Opioid Treatment Program, in December 2019, but actually went live March 20th at the apex of at the advent rather of the COVID pandemic. 3 addictionologists and an addiction nurse practitioner are contracted for clinical services and oversight of our OBOT program, which is now fully integrated into the service continuum at Metropolitan. Of concern, however, is the slow uptick in patients seeking opioid treatment services. I think that's been really concerning, particularly given some of the data that has been shared with you all. And also because we are in a COVID pandemic. And this is despite increases in use of all substances, as well as has been reported, the deaths due to opioid use in particular. Narcan trainings and distribution has been an integral part of our opioid effort. Non-traditional partners, as was mentioned earlier, have been a target. First responders, schools, churches, beauty and barber shops, to name a few. We work very closely also with the City of New Orleans, coordinating care for behavioral health services via the Behavioral Health Council, which provides projects and initiatives that expand communication awareness to our larger population and constituency. It is our relationship with the city that has fostered a lot of the work, and with the state, Office of Behavioral Health in particular, that has fostered a lot of the work that we're currently doing to assist the evacuees from our sister district, Imperial Calcasieu. That's a hand-in-glove activity where we're providing a lot of the behavioral health services on site at the resource center, and also at some of the hotels in the area. Our crisis response team has been tremendously valuable in being able to provide support for the services needed for those individuals who remind us of us during Hurricane Katrina, when we were desperate and destitute and in need of a caring voice and a loving and kind hand to provide some support. So we're working closely with the city on that effort. Metropolitan also partners with the graduate medical education, psychiatry, and psychology programs at both Tulane and LSU Schools of Medicine for all child and youth services at MHSD. This offers a tremendous advantage to our community with the resources to younger people under age 21, which represents 20% of our population. Our in-house CEU program has been supported by MHSD physicians and legal staff, along with our graduate medical education attendees. This allows a lot of the psychological testing that we're able to do, which often is so very important in determining what some of those early conditions are that may have been the result of in utero exposure to substances perhaps, or behaviors that are difficult to discern, and psychological testing becomes really important in making the distinction between an ADHD or PTSD, which are often equally misdiagnosed in some settings when the diagnostic criteria is not so very clear. So that's a tremendous advantage that we have a training program that's taking care of our kids. Grants have been extremely sustaining financially for increasing our peer employees and our outreach network. Grants which have included peer services, and typically when we get grants, we have been fortunate enough to write in a component of the grant services to include peer services. Examples have included the Medication Assisted Treatment Grant, which was the first grant we received in 2016 for 3 years, which sort of launched the work that has been done to address the opioid epidemic in our state. That grant was awarded to the Metropolitan. The Louisiana State Opioid Response Grants, the LeSource grants have all included peer work. Our local grant was somewhat unique in that we used it as an opportunity for community outreach, taking advantage of all of the different festivals and venues that are provided for contact with the general public. The COPE grant, which is housed in the local jails, has been important to providing services to people who are incarcerated. And that grant is primarily provided, the services are primarily provided by our peers who are supervised by one of our staff. And then Baptist Community Ministry grants have been important because they have funded what I mentioned earlier, our Faith Partners Initiative, which has been a very, very important component of what we do in Metropolitan, which is to bridge the divide between faith and science by partnering with clergy of multiple denominations to help them understand addiction, mental illness, so that they can recognize signs of difficulty in their congregation members and have a relationship with us that they trust and are willing to refer them to us for professional help. We act as conveners for meetings as well as consultants to the faith-based partners in this initiative funded by Baptist Community Ministries in the past. And then we also have a beauty and barbershop initiative, which is also part of our community outreach project with the purpose of identifying hotspots where substance use is problematic as well as mental illness, so that we can develop those relationships with the general public who frequent those establishments and know of and are concerned about, but perhaps have never been exposed to or had an experience of seeking professional services. That's an important part of our outreach, and that is all grant funded. So harm reduction has been a very, very important part of what we do and has been highly embraced into our culture, both directly in the delivery of services and also in the manner in which we engage our relationships with each other. 6 hours of training, for example, were required by each Metropolitan employee on understanding various aspects of working with the LGBTQ plus population during this past fiscal year. That is very important because very often people are judged by our opinions of them, and so that interferes with the service delivery because it interferes with people feeling comfortable coming in. And so understanding the population has been very important, and we have provided the opportunity to have a consultant come in and to provide information on that, how to work with LGBTQ positive populations. Our HR division is currently providing information in the form of videos and reading materials to prep for an upcoming quarterly in-service this week entitled Embracing Our Differences. It's very important at Metropolitan that we do not ignore the signs of unrest, social unrest that are occurring in this country, in our world, in our communities, and the impact that that is having on our employees as well as on the persons we serve. And so in order for us to better address and meet those needs, we are doing in-house in-service to address our differences so that we can be more sensitive to the differences that people bring to us, substance use disorders, mental illness, and are more objective in our ability to provide them the best quality services. Aligning this with social unrest in our country has been this is aligned with the social unrest, as I mentioned, in our country. And then the aggressive expansion of addiction services within the district is intended to also decrease stigma and reset sensitivities to our populations who present with a complex set of challenges. Finally, I mentioned our investment in crisis response, but that investment in a crisis response team, which includes a division within the agency that goes out with crisis-trained police to de-escalate situations in the communities, which often involve substance use, but sometimes or primarily mental health related. That expansion of that team has included the hiring of crisis response counselors who work in our clinics and also are able to be dispatched into the community for crisis situations. And so this has been a tremendously wonderful investment we've made because it is the primary manner in which we are able to help the evacuees from Imperial Calcasieu District with the difficulties and the challenges that they're experiencing. So the combination of hurricane season, the COVID epidemic, and what we're seeing as substance use rearing its head as well, makes for a very challenging mix of needs that we have to be postured to assist with. And our crisis program has been able to do that. So these are just some of the things that Metropolitan has put in place. It is a part of a large puzzle of options that we continue to edit, change, and adjust to address the needs in our community. Metropolitan is poised and nimble in fulfilling our mission of being the place where we change lives. Please don't hesitate to contact us if services or supports are needed. And thanks for the symposium. I think that it has had a great start so far. And for all of you who are attending, I hope that you enjoy the remainder of the conference. Thank you.
Thank you, Dr. Dunham. As always, you really so eloquently described the collision course, as you called it, between the opioid epidemic and COVID-19 from a real kind of boots on the ground perspective. And of course, want to remind everyone, especially that the beginning part of your presentation, that you are a medical doctor and one of the state's leading addictionologists. So it was just very compelling to hear you talk about literally how the body responds, and it makes you more potentially vulnerable to COVID-19. So I think that was very educational. You said a line that I wrote down. To me, it kind of summed up a lot of what we're talking about, which is addiction is a disease of isolation. And I don't feel like we've ever been more isolated than in COVID-19. So that kind of really just brought the whole reason home for me. You also did a really good job of doing some teasers for some sessions we have over the course, whether you meant to or not, over the course of the next couple of days. You mentioned social determinants of health, of really being so important. Tomorrow morning, we have our keynote address by Dr. Benjamin on behavioral health disparities. You also mentioned telehealth and the value that kind of this resurgence of value in telehealth that we've seen because of COVID. And there is a telehealth session on Thursday morning at around 9:30 that will go through some data and the extreme trends and utilization in telehealth, since we have both re-advertised people who can use telehealth and expanded those who can, specifically in the substance use disorder treatment field that did not have that availability before. And we'll see some data on that. So I would ask people to tune in. I want to let people know that the question and answer box is open. I think we've received a few questions to the chat room. However, I do not have access to the chat room right now. I do have the question and answer box open. If you would like to submit some questions, we've got a few minutes, and all of our panelists have graciously stayed around to answer any questions. In the meantime, Dr. Dunham, I hope you don't mind me putting you on the spot, but you talked about the slow uptick in treatment, yet we've seen in the substance use world an increase in overdose, and you touched on maybe why, but anything else we can talk about? And then you also did a really good, nice job of talking about how the advertisement of your services, so maybe people out there that'll hit home that there are services out there. Any other kind of ideas why a slow increase in treatment, or anything else you'd like to add around that topic?
So yeah, I have given some thought to this, and I think the logic model behind survival helps us understand some of what's going on. Typically, and I always try to reference myself, Karen, in terms of how I manage and how that might help understand why other people manage the way they do. Because even though people have the disease, the brain disorder of addiction, it doesn't make them any less human than it makes us. And so there's some common threads in terms of how human beings adapt and cope, which is why I brought in the whole cortisol idea in this discussion. But we tend to be creatures of habit. And when things are too devastatingly unfamiliar to us, our fallback is our familiar. So what do we automatically do when things seem completely unmanageable or completely foreign to us? A lot of people have been eating too much, right? Because they tend to eat a lot when they get under stress. A lot of people have been maybe watching a lot of television or drinking more wine. There are just a lot of things that people have been doing. Well, why would that conversation not be any different for a person who has a substance use disorder? What substance users do is they use substances, and they have used them for years to address uncomfortable emotional states. That's why they use. And this is a very uncomfortable emotional state we're in. Why would you try something new necessarily if you know what you're gonna get as an outcome from your familiar? And so I think people are not willing, if they've not been in treatment, this is not necessarily for many people, the time to go to treatment, because treatment itself is a mystery. And how does that work? And typically substance use is not an overt condition, it's a covert condition. And treatment really expects you to completely open and revealing. So why would I do that? That's stressful in and of itself. So just the nature of what we do in the delivery of services, I think runs counter to our natural instinct when we are under stress. And so we're just not getting as many people in, no matter what we're doing. People are resorting to familiar behaviors. And we do know, some of the data you've seen shows that people are using more. They're using more drugs, they're using more types of drugs because they're trying to cope just like all the rest of us. Unfortunately, their go-to is a behavior that is deadly, especially in the face of coronavirus.
Wow. Well said. And let me apologize. I realized I'm looking down, and that's because you're on the screen right in front of me. For the viewers, if it looks like I'm looking down, I'm looking right at Dr. Dunham like we're having a one-on-one conversation, and just realized for the rest of the viewers are out there as well. Dr. Dunham, you also said something I wrote down that made me want to advertise a few resources. And if you have any additional resources in the New Orleans area, feel free, in addition to what you said, feel free to speak up. But you mentioned that the heightened anxiety is a trigger for use. Of course, we know that. And so we have advertised and set up a few resources for Louisiana residents. We have a Keep Calm hotline. It's a 1-800 hotline that allows anyone to call and talk about the stress and anxiety. There are trained people on the line to do some stress management techniques, to listen, to de-escalate a crisis. And this could be whether it's around COVID-19 or around Hurricane Laura, or the intersection of both of those. We also have a specific hotline for those in recovery. And so it's answered by also people's trained in the same way, but more peers. And so one of the things we realized early on is that this anxiety and the need for information and comfort really is really needed in a vulnerable population. So we set up a specific line that's for the state of Louisiana. Dr. Dunham, do you have any lines that you would like to advertise for the New Orleans area, or a website if you would like to say it?
Yeah, we have, our central number is 504-568-3130. That is our entree number into everything Metropolitan, 568-3130, 504. If you call that number, that phone line will be answered by our care center. And our care center filters about 50% of just informational calls. The other 50% are actually for services either that result in us delivering a service or them being referred out for other services. So 504-568-3130 is the number it's the only number you need to know for Metropolitan. The second thing is visit us on the website at mhsdla.org. All of our services are listed on the website. That website is updated with frequency, and so it should be current, but it's mhsdla.org. And Karen, I wanted to add to the whole anxiety piece as it relates to substance use. It's at a whole nother level with a person who has a substance use disorder. It's almost like you have now kicked their brain into a whole nother gear when anxiety comes into place, because now you are involving the inability of them to even really think clearly. So their frontal lobe gets hijacked, if you will, with thoughts of using and doing whatever they need to do to get drugs in order to get through that anxiety event. The very thing that you need to do in a crisis is to be able to think clearly, is to make good decisions. Is the very thing that gets impaired when a person has a brain that's been exposed to substances and are now in a heightened anxiety state. So understanding that and helping people with a lot of coaching, cognitive therapy, and helping them to make the right decision becomes very, very critical. So it is help, but it's specific kinds of help that we have to be able to offer people who have substance use disorders.
Thank you, Dr. Dunham. We did receive a question about the role of prevention in opioid use disorder. And I was looking down, trying to look through the agenda over the next few days because I knew we had at least one around prevention. And of course, people think of prevention, in a couple of different ways. We have some evidence-based models. One of them is specifically called Generation RX that has different modules of a curriculum geared towards different age groups. There's a model for older, more mature people. There's a model for adolescents. There's a model for young adults that can be implemented. Another really important key in prevention, and it's something that I hope we start to spend more time around, our non-opioid alternatives to pain. And I was looking, I believe there is a session in this summit on non-opioid alternatives. So, preventing is of course never starting. And so one of the keys is, that quick to prescribe the opioid for pain when there's some research that in some cases, the opioid actually doesn't work any better than kind of a basic over the counter. And so I would encourage people to attend that session as well. I just received a 5-minute flag. And so I would like to take a second, we don't have any other questions in our chat box, to ask our panelists, Nell, District Attorney Moore, if there are anything else that you would like to stand up and say in closing, anything as you heard the other panelists speak that kind of came to mind that you would like to share. Nell, I'll start with you. Are you good with your data? When we all look forward, I'm sure you'll see an increase in the number of hits on your LODS website now that you've advertised it. Yes. District Attorney Moore, is there anything else that you would like to say? Or Mr. Daniels? Great, thank you. Dr. Dunham, any closing comments from you as well?
The only thing I'll say is this is a wonderful opportunity, I think, for people to get immersed. Any opportunity to understand substance use is a wonderful day for me. So I am so appreciative of this conference and the expanded knowledge that we'll all have as we move forward. So thank you, OBH, for putting this on.
Thank you for volunteering your time. I would like to close with completion of the quote that I started with. And because I find it motivational, I find it timely, and really just brilliant, like most things from Maya Angelou. But she said, "You may encounter many defeats, but you must not be defeated. In fact, it may be necessary to encounter the defeats so you can know who you are, what you can rise from, and how you can still come out of it." And I think that is never more appropriate than right now, when it seems like Louisiana keeps getting knocked down, and we need to know that there's a higher meaning, a higher power, and a bigger picture. And with that, I feel like it's very fitting to hand off to my boss, Mr. Mark Thomas, who I often find also inspirational. And so he will come and join us for just a few minutes. Mr. Thomas, if you would like to stand over there, we will get you, I believe this is a fresh mic that's been wiped down, and we will allow you to close out this morning. I would like to remind everyone there's an afternoon session, and then the actual symposium kicks off tomorrow morning on Wednesday and Thursday, and has a nice consistent line of opioid related topics if this is your interest. So thank you, Mr. Thomas. Yes, sir.
Thank you, Karen. Let me first start by saying the quote that Karen ended with was what I was going to open up with. No,
Are you
I'm
kidding?
just kidding. I'm just kidding. You know, one of the things is, I think it is, as Karen said, you know, the resiliency of the citizens of our state is being tested. And it seems as though there's one thing after another, one event after another. And one of the things we say is that we're built for this. This is what we do. This is what we've dedicated our lives to. And so to all of our speakers who have gone before me, thank you for the work that you always do, but more importantly, the work that you're doing in these tough times. I want to also say thank you to Karen and Women's Hospital and the organizers and coordinators of this event, because if there ever was a time for this type of symposium to talk about the topics that we're talking about today, now is that time. Very thankful to the planning committee as well. Up to this point, we have heard from many different subject matter experts who have, I'm more than certain, comprehensively covered behavioral health, addictive disorders, and none better to do so. And so when I talked to Karen about what I should close this session with, first and foremost, I'll tell her never ask a pastor to close a session. Just a little word of wisdom there. But also, she gave me the green light to talk about, to change the conversation, to change the topic a little bit, to give a little bit of my heart and to talk about where we are as citizens of our state, as well as you know, the Louisiana Department of Health. I'm so thankful that the governor and Dr. Phillips and others have gone before me, and I'm gonna do my best to not repeat some of the things that they have said. And so as I change the topic and change the conversation, I'll speak a little bit from the heart. 15 years ago, I did not have a true appreciation of mental illness and substance abuse and their impact on the lives of everyday citizens. In my mind, the need for mental health belonged to those with a clinical diagnosis. The trials of substance abuse were reserved for the homeless and those who had lost their way in life. That was until our state experienced Hurricanes Katrina and Rita. With my wife and I being from New Orleans and Lake Charles, respectively, we watched firsthand as our immediate family members struggled with mental health issues and dealt with substance abuse resulting from the trauma imposed by these two major storms. Now, fast forward 15 years, and here we are again. Only this time, take into consideration that we are experiencing an event that may be more subtle and invisible, but more impactful based on the number of people impacted and dying of COVID. Back then, it was New Orleans and Lake Charles. Now it is our entire state. Back then, it was them. Now it is all of us. There's not a person in this room that has not been impacted by COVID in one way or another. It hits home for every single one of us. As I talk a little bit about the impacts of COVID and how it impacts our mental health and so forth, it makes me think about my daughter. Makes me think about my daughter. She turned 18 this year with no real birthday party. She graduated with honors, high honors from high school with no graduation. She is a Bible quizzer who made it to nationals, but did not get the opportunity to compete. She is a championship bowler who did not get to finish her senior year bowling. She started college this year, but she's having to do it online, and I can't tell you how hard that is for a socialite. As I began to ponder, I thought this has got to be depressing, and I wonder if she is okay. So I asked her, what are you living for in these times? What do you have to get excited about? Her response was, "Are we still getting the new living room furniture?" And I thought, oh my gosh, what has this done to my baby? Have you ever seen an 18-year-old get excited about furniture that didn't go in her room? This has got to be depressing. I tell that story to make you laugh, but there are folks who are going through much tougher times. Imagine living in the midst of a worldwide pandemic where you have gone months with no meaningful contact with loved ones and coworkers. A world where distancing is encouraged and isolation is the new norm. Now compound this with living in a nation that's experiencing levels of social unrest not seen in 50 years. Folks are dying, people are angry, and the leaders who are supposed to bring peace and balance have taken sides. With an impending national election that is likely to tear our nation apart. As if this was not enough, in the middle of the night, a massive hurricane has come upon our state, the likes of which not seen in 100 years. You run to avoid the devastation only to return home to a community and a city that is ravaged by destruction of property and loss of life. Of course, your next steps are so obvious. You evacuate to a shelter, to a place that in your mind, super spreaders are ready to transmit COVID to you and your family. You now know that they are the people that do not look like you, the ones you're supposed to be separated from. Alas, there's a better solution. You know, the one where you get to evacuate to a hotel so you can continue to social distance and further isolate yourself from humanity. I was in New Orleans on yesterday, and I heard folks who were scared to come out of their room to get their meals for fear of contracting COVID. I heard from folks who said they didn't have much to begin with. And now, after having gone home, to know that that very little that they had to begin with is now gone. I heard stories that people that had evacuated to the hotels were getting rowdy and things were getting out of hand. What I found was absolutely the opposite. As this conference is being broadcast from a very nice and lovely hotel, and it has many guests who have evacuated, it's silent around here. If you haven't noticed, as I did yesterday visiting 3 hotels, many of those individuals are subdued. Many of them are troubled. Some have even shut down. I talked to people that were afraid and anxious, trying to put on brave faces for their children and sometimes their elderly parents. And as I thought to myself, there has never been a more important time to have a robust behavioral health system. The time is now. We need crisis services now more than we've ever needed them before. In addition to that, we recognize that the COVID pandemic presents unique challenges for people with substance use disorders and in recovery, since substance use may put people at increased risk for infection or the most serious outcomes of COVID-19. Several research projects will be assessing this, but people are looking at smoking and vaping, both of nicotine and cannabis. These may be risk factors for worse COVID-19 outcomes. So we are funding supplements, and we're funding and looking to ways to better meet the needs of these individuals who are most vulnerable. As I listen to the presenters, and as I listen to those individuals who have been impacted, and believe me, I do listen because, as I said before, these are my people. I'm from Lake Charles. I've had to evacuate family personally, and I've seen the devastation And so as I listen to these individuals, I ask that we listen with an open heart. I ask that we work as if it was one of us who is in distress or in need of services, because this is who we are. We are Lake Charles. We are the state of Louisiana, and we are resilient. Karen, thank you for this opportunity.